Now moving on to the next very important bit is MI and its localization. So either way, the first thing I want you to remember is one, AVL, V5 and V6 are your lateral leads. Lateral leads. So they are looking at the left circumflex artery. The 2, 3, AVF are your inferior leads. So they are looking at inferior wall MI, which is usually right. And V1, V2 is septal. So septal, again left anterior descending. Okay, so this is just the graphical representation of what I already wrote. So if you want these notes which I am using right now, they will be available on my website. The link will be in description. You can go to my website and under the free. But even before we go for this uh, MI, there is one thing you have to know. If there is an acute chest pain with pericardial rub, pericardial friction rub, and you get, see, this is what would be the diagnosis? And a concave up ST elevation. This is a again very key point. Normally, MI will present with something known as convex upwards. So if a MI is presenting, there will be this, the QT prolongation will be like this. It will be a convex pattern, and this is known as Pardy sign also. Again, if you need to know, if you want to know, you can Pardy sign, also known as tombstone pattern, because patients die. This is the NY. But if it is a convex upward pattern, if it is pattern ST elevation is somewhere like this, it is a convex upwards. This is seen with pericarditis. Very important. So we'll go with pericarditis. So how the patient will present pericarditis? Pericarditis will present with a sharp pleuritic, a sharp chest pain kind of thing. MI has a very dull chest pain. It will present in pericarditis. There are two types that are usually asked in PLAB. So if a patient has MI and he develops this pericarditis like features within 3 weeks or within 2 weeks, it's usually post-MI pericarditis. It's just called that. But if the patient develops this same thing after 4 to 6 weeks, it is known as Dressler syndrome. Again, I'm gonna write the name in capital letters. It is Dressler syndrome. Both have the same treatment. So initially you just give NSAIDs, but if they ask you what is the supplemental drug you're gonna add, so a patient who is on pericarditis, he is still having pain even after giving NSAIDs, you're going to add colchicine. One of the very confusing options they give you is prednisolone. So you won't add a corticosteroid. Very important. Remember this. Don't add a corticosteroid. Go with colchicine. Colchicine is a microtubule inhibitor, and that's how it works. Again, a very weird question per se, but sometimes it does get asked. You see this pattern, this ST elevation pattern, this coving. It is known as a coving pattern. If ever in any question this coving pattern, again when I see this, I see my eyes directly go to V2. There is ST elevation V2, V3, V4. MI is always with reciprocal changes. Okay, remember this. If there is MI, there will always be reciprocal changes. So I see reciprocal changes. Where do I see reciprocal changes? I go here in lead 2, 3. There is ST depression. You see T wave inversion, ST depression in 2, 3 AVF. I can see. So this is in T. Okay. So we'll go to just a bit more details on how to. So in MI first, we'll get a hyperacute T waves. Don't use the word tall tented T waves. Tall tented T waves are for hyperkalemia. So you'll get a hyperacute T waves. Following this, there'll be ST elevation, and following ST elevation, see, then. So now moving on to the treatment of STEMI. Yeah. So for STEMI, we have this mnemonic MONA or MON. It is PCI. PCI is percutaneous coronary intervention, and there are different guidelines on how to do it. Like there is a 90-minute door to balloon timeline, or there is a 120 minutes if you have to do rescue PCI. Anyway, moving on. Long term, we can use aspirin. So you have to give aspirin for life. Again, ACE inhibitors and statins for life. Again, this is the question they ask, like, what are the drugs which are given for life? Or they'll give you a list of medications the patient is on, and they'll tell you what else do you need to add. So for the initially, this is how I'll write it. So once the patient gets MI, I'll start him on aspirin, statin, plus an ACE inhibitor and ARB. This is, and I'll tell him you have to take lifelong. Along with this, I'll start him on clopidogrel, pasogrel, or ticagrelor, depends on this for 12 months, and a beta blocker for 12 months. So this is what you have to remember: ACE inhibitors, statins, and aspirin for life, followed by clopidogrel and beta blockers. We also start for the first 1 year of the patient. And for non-STEMI, always remember, never, 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 don't make this mistake. Never thrombolize, never do PCI. The clot in STEMI is a platelet-rich clot. It's not a fibrin-rich clot, so it is not going to break. And if you do break it, it's going to break into more smaller pieces, and it will spread over a longer, like a larger area, and the patient will develop more like an STMI might become a an STMI might become an STMI. So how do you treat? We give just aspirin and fondaparinux, and then there is again more complications to it if you really want to go, but not ask. There is something known as TMI risk score, and then we grade the patient and see if the patient is going to develop. Yeah. So you see, so this is the QT interval, right? So from see, QT interval includes a Q to T. If this is if QT and this is the RR interval, right? If QT interval, see, it is not even half. But if QT interval is equal to more than half of RR, that is a prolonged QT. Simple. So again, if for a different ECG where there is a proper QT segment, okay, I mean you can use this. Let's see. You see, it goes from so from here to here. This is QT, and suppose this is RR. So again, it is not even half. If it is more than half of R, now going on to the last two questions, there is hyperkalemia. Hyperkalemia is very important. Hypokalemia they ask. So what happens in hyperkalemia? Just remember one, and then you flip the other one. So what happens in hyperkalemia is there is peaked T waves, right? So if you remember peak T waves, you can also remember there is ST elevation, right? Because ST is also like going up. So this is suppose say QRS, then there is ST. So if T is going up, it will pull the S wave also. So there is ST elevation with peak T waves, and P wave will be gone. There will be P wave loss or flat P waves. So I'm gonna write this here, how to make it simple. So for hyperkalemia, what you're gonna write is there is peaked T waves. When you remember peak T waves, you'll also remember there is ST elevation, right? So because T and ST are very connected, and this sorts here a lot of questions. So with hyperkalemia, we have dangerous levels. So see, anything more than 5.5, anything more than 5 is can do is you can stop the drug and ask the patient to repeat, and since it's mild hyperkalemia, it's going to come down automatically. Then we go for moderate. Now if the value is between 6 to 6.5 or 6.4, whatever you want to remember, then you have to see if ECG changes are present or not. If ECG changes are present, you have to start IV calcium gluconate. You have to start IV calcium. If ECG changes are present, you have to start IV calcium gluconate. Very important. Because IV calcium gluconate, what is going to do? It is going to stabilize the cardiac membrane. So this is not going to change potassium levels. Very important. You have to remember, it is not going to alter potassium levels. Potassium levels are still going to be high, but it will going to stabilize the cardiac membrane, so the patient does not go into arrhythmia and die. Because what's the whole point of decreasing the potassium level if the patient dies before that, right? You're not treating cadavers. So we have to stabilize the cardiac membrane. So for that, we'll give IV calcium gluconate. This is going to stabilize the cardiac membrane. Now what we can do, if potassium is more than 6, after you stabilize, if the potassium is more than 6, then you give insulin with dextrose. Insulin is going to drive the potassium inside, but since insulin causes after the calcium gluconate to stabilize the membrane, and this sorts this. So we have just two more things to discuss before we end this long video about ECG, and I really hope you got some value out of it, because it does take a lot of time to make. So yeah, please let me know in the comments. So how do you calculate the left ventricular hypertrophy? So what you have to go for, you have to see height of or depth basically of S in V1 or V2, V1 or V2, whichever is larger, plus the height of R in V5 or V6, whichever is larger. Now, if this height is more than equal to 35 millimeters, or what we can say 7 large boxes, okay, 7 big boxes, this is left ventricular hypertension. So how do you say left ventricular hypertrophy? See, we'll say, I'll take V1 because V1 is longer. So 1 2 3 4 5 6, it's already 6, so I just need one more box, right? So I need one more box. Obviously, say V6, here is V6, 1 2 3 4 5 6. So it is again 12 large boxes. So this is proper left ventricular hypertension. That's all you have to count. Okay, or 35 millimeters, because one small box is 1 millimeter. So you can get, or there'll be large. So 7 large boxes, 7 large boxes. How much one large box has five small boxes. So 7 5s are 35, which is 35 millimeters. Do you get it? So either seven large boxes or 35 small boxes, also known as 35 millimeters. That is how you know there is patient has left ventricular hypertension. So again, height of S in V1, R wave in V5, V6. If it is more than 35 millimeters or more than equal to seven large boxes, this sorts this. So for bundle branch blocks, there are two mnemonics which are world famous. There is Marrow, Marrow, and William, WILLAM. Why I'm writing it like this? So you remember from right Marrow. So in lead one there is M. So in V1 there is M pattern. This is for Marrow is for R. R is for right bundle branch block. And then there is left bundle branch block LBBB. That is left bundle branch block. So height in V1 there is M pattern. This M pattern is also known as RSR. You see there is a small r, then there is deep S, and then there is another big R. This looks like a M, right? This looks like a M if you draw it like this. This is known as the RSR pattern on the M pattern in V1. And in V6, we have sloping of the S waves. So there is this R with very big S. So this thing, this is for right bundle branch block. So in general, when you see the question in paper, how do you know that it is a bundle branch block question? The first thing you have to see, there'll be a broad QRS. Okay, if you see a broad QRS, then you think, okay, there is something, there's some problem. Now, if there's a broad QRS, which is in normal, so there is no tachy, there is normal rhythm, broad QRS, and there is an M pattern in V1, that is a right bundle branch block. Now, on the other hand, if there is a broad QRS, but there is this M pattern in V6, you see M pattern in V6, then this is left bundle branch block. And this is how you remember. So in simple, I'm just going to go simply over it. If there is a, you remember this Marrow and Williams, so M pattern in V1. If you see M pattern in V1, this is normal. See, this is normal. This is M pattern, RSR pattern. If you see this M pattern in V1 and a broad QRS complex, this is a right bundle branch block. And then you can see, if you remember the S pattern in V6, V1, V6, it's okay. But then again, for PLAB, they give a very typical ECG. So if you see a broad QRS with M pattern in V1, that is right bundle branch block. And if you see this M pattern in V6, this is a left bundle branch block. And that's it. And how you remember? William. So V6 has M pattern, Marrow, V1 has R pattern. So R. So William has two L's. This will remind you it is used for left bundle branch block. And Marrow has two R's. It will make you remember it is used for right bundle branch block. And I think that covers all of your questions for ECGs when it comes to PLAB. And we also completed the guidelines of different managements and how to identify ECGs. This was, I think, pretty comprehensive. And I think if you just do this much, this is enough for you. There are certain things I have not touched, like this the Scarbosa's criteria, but for left bundle branch block with MI. But again, that is not asked for PLAB. So even if you do know it, I think you don't need to go in that detail. I just covered the clinically relevant points which are needed for PLAB, and in general, just for a first foundation year trainee doctor. And then the more you study, the ECG is like a never-ending field. So the more you go into the depth of it, the more you'll realize there are more patterns, there are more terms, there are more criterias. So yeah, that will be all from me. I hope you found this helpful, and thank you for watching.